So I have been asked to speak about acute kidney injury. I will present my lecture here as I have learned nephrology in my DM nephrology course and what I have been practicing for last 25 years in HRC. So I'll give you the most just practical approach to the acute kidney injury. Medavi, who has come from all the way from Lucknow. Thank you, Medavi. And yeah, so let us start. This is a section of the kidney. This is section of the showing. This is a kidney, renal vessels, vein, artery, and ureter. So we'll build up on this. There are only 4 conditions in the nephrology or in medicine where serum creatinine rise. और किसी में creatinine बढ़ता ही नहीं इस 4 condition के अलावा. So these are the 4 conditions. And acute kidney injury, chronic kidney disease, rapidly progressive glomerulonephritis, acute nephritic syndrome. These are 4 conditions, top 4, where serum creatinine rise or GFR falls. If these conditions and treated well in time, there are you can reduce the patient going into CKD. We have I have already told that going into the CKD is once the patient reaches to end-stage renal disease. Once the patient reaches to end-stage renal disease, the life expectancy becomes very less and survival is dependent on maintenance hemodialysis or renal transplantation. Transplantation is not as good as patient on without dialysis. So really life becomes hard with patient on dialysis. You have to go 3 per week or 4 times in a week for dialysis, 4-hour session daily, almost needle pricking, taking injections, taking iron injections. So a lot of problems are there. So early, so the role of nephrologist or role of any physician is to prevent the deterioration of kidney function or to prevent acute kidney injury into chronic kidney disease. So acute kidney injury is defined as sudden deterioration of kidney function over a period of days to weeks. Chronic kidney disease is very important. There is once you diagnose the chronic kidney disease, there is relentless. Once you diagnose chronic kidney disease, it means this patient will progress and ultimately reach to end-stage renal disease. And this is defined as structural or functional abnormality in kidney function which persists for more than 3 months or decreased GFR for more than 60 ml per minute. It will persist for more than 3 months. This is called CKD. And once you diagnose continuous ambulatory peritoneal dialysis or renal transplantation. Rapidly progressive glomerulonephritis is very important. This is a medical emergency. This is an emergency in nephrology. Identification of this is very important. Patient usually present with a rise of serum creatinine, rise of deterioration of renal function over a period of weeks to months. Suppose patients come to you today well in time. Mind it, if you treat this patient well in time with immunosuppression, there are 40 to 50% chances that patient will have recovery. Otherwise, if you fail to diagnose this patient at this stage and if you fail to treat this patient at this point of time, this patient will go into chronic kidney disease. And once you reach chronic kidney disease, the life will all be dependent on maintenance hemodialysis or renal transplantation. So if you diagnose the syndromic diagnosis is RPGN, you do biopsy. Biopsy will have crescents. If you have crescent more than 50% crescent, you treat with immunosuppression. Methylprednisolone, methylprednisolone, plasmaxine, endoxone. There are different protocols for this. And by this aggressive management, you definitely can. Recently, we saw 2 or 3 patients in nephrology OPD who presented with lady, especially presented with RPGN. And ultimately, the biopsy was done. They were having crescents for more than 70% crescent, and the basic background was the lupus nephropathy. They were dialysis dependent and they were treated with immunosuppression. Now the serum creatinine has come down to 1.1. So this is the magic of early diagnosis and aggressive treatment of rapidly progressive nephritis. I again emphasize that do not forget, do not neglect serum creatinine 1.7, 1.8. This is very important. The diagnosis of kidney function, diagnosis of renal diagnosis at this juncture is very, very important. If you fail here, then ultimately then you the kidney become fibrotic, and fibrotic means end-stage renal disease, and the things will not be as good as would have been. 4th condition is acute nephritic syndrome. Acute nephritic syndrome usually present with hematuria, proteinuria, edema, hypertension. This is although most of the time this is post-infectious. and sometimes this may also go into cystic nephritis. If this is also diagnosed well within time, things become reversible. So out of 4 conditions, 3 may be reversible. If you treat them well within time, they are reversible. And chronic kidney disease is irreversible. Once you diagnose chronic kidney disease, problem of patient will go into end-stage disease, patient will have the patient can have heart failure and will go into cardiorenal syndrome and many other complications. Now, definition of AKI. There are 3 criteria of diagnosing acute kidney injury: Rifle criteria, Akin criteria. Akin means acute kidney injury network, and KDO criteria. The criteria, simple definition wise, increase of serum creatinine more than 50% developing over 7 days, and urine output criteria. Normal urine output production is 1 ml per kg per hour. If less than 0.5 ml per kg per hour, follow more than 6 hours, it means the patient going into acute kidney injury and become watchful for this. And there are different criteria of diagnosis and staging of acute kidney injury: Rifle criteria, Akin criteria, and KDO criteria. Now, types of acute kidney injury. The kidney has got 4 components. Kidney has got blood vessel, kidney has got glomerulus, kidney has got tubule, kidney has got interstitium. So involvement of any of these structures can give rise to acute kidney injury. Most common is pre-renal. If pre-renal means there's something happening before the kidney. And what happens before the kidney is the renal perfusion becomes low, and this happens into hypotension, shock, especially hemorrhagic, volume shock, dehydration, gastroenteritis, burn. Anything which is causing renal circulation less, hypotension will give rise to pre-renal conditions. If pre-renal conditions are not treated well within time, this will go into acute tubular necrosis. Acute tubular necrosis, and acute tubular necrosis is also a good diagnosis because most of the patients, 80-90% patients will recover with a good supportive care. And the renal cause of renal failure, the various type of glomerulonephritis, tubule interstitial nephritis, and vessels vasculitis. And post-renal causes are, post-renal causes, but the events are happening after the kidney. After the kidney means there is pelvis, there is ureter, there is bladder, there is urethra. So any obstruction down the line in the kidney will give rise to post-renal causes of renal failure, and these most of the time this is obstructive. If you, in Bundelkhand, there is a problem. We often get neglected renal stones. Patient usually, many of the patients, this is one of the common reasons of chronic kidney disease in Bundelkhand. Neglected renal stones. They are harboring renal stones in the kidney for last many years, presenting with infections, obstruction, and an infection or obstruction will lead to acute chronic kidney disease, and life become really hard. Recently, I have seen one patient, one kidney was small, and there was ureteric stone. The serum creatinine was 13, and with the intervention, now creatinine has come down to 1, and patient has been discharged. So the idea is the early identification of correctable factor. Whenever you get any patients of chronic renal failure, renal failure means serum creatinine, rise of serum creatinine, or decrease of GFR means renal failure. Whenever you get any patients of renal failure, you always try to find out correctable factors in that. Look for hypotension, look for obstruction, look for renal vein obstruction, look for artery obstruction, look for ureteric obstruction, look for prostate disease. Many of the patients come to with a neglected prostate, with obstructive symptom for many years, and bladder is thickened. Be careful of never use NSAIDs in the acute kidney injury. Try to avoid ACE inhibitors or ARB. There are certain indications for that. And any drug which you want to use in a kidney failure patient, look for GFR and give medicine according to GFR. Because I have seen many patients, cephalosporins causing encephalopathy. Many patients I have seen cefepime. Patients were having full dose of cefepime and advanced renal failure. Patient presented with encephalopathy. Drug was taken, good supportive care, improve. Many of the patients ciprofloxacin taking full dose of ciprofloxacin or quinolones, any ofloxacin, and a renal failure, they present with convulsions. So convergence and this thing, personal tazobactam causing from drug toxicity. And very simple, just suspect drug toxicity and consult the paper instead of that medicine. So simple, it's not a big thing. Just suspect the culprit drug and see the paper instead of that drug, you will find a solution. Withdraw the drug, reduce the drug, or dialyze or give supportive care. So patient will definitely may improve. 3 to 7% of hospitalized patients and 25 to 60% of ICU patients they develop AKI. Increase in serum creatinine always associated with carries increased chances of mortality and morbidity. Causes of AKI we have discussed. Just to revise the list. Causes of AKI, most common causes of AKI are diarrhea, vomiting, hemorrhage, trauma, excessive dialysis, burn. They cause volume loss, hypotension, and ultimately leads to ischemia of the renal tubule and tubular necrosis. If the tubular necrosis and second is decreased effective arterial volume, blood volume. Patient is not having diarrhea, vomiting, hemorrhage. That is volume loss is not there, but effective arterial perfusion is less, which is very common in cirrhosis, nephrotic syndrome, cardiac shock, sepsis, anaphylaxis. Because these conditions give rise to massive vasodilatation, and massive vasodilatation will give rise to decrease effective arterial blood volume, which causes less perfusion to the kidney, and less perfusion to the kidney will give rise to ischemic injury to the kidney and will give rise to acute kidney injury. So renal causes of acute kidney injury, acute tubular necrosis, nephritis, microvascular involvement, malignant hypertension. These conditions are also treatable and reversible if you diagnose well within time. Post-renal causes, outlet obstruction, bilateral ureteric obstruction. Now clinical assessment, very important. Hemodynamic assessment. Any patient of renal failure comes to you, first assess hemodynamically. Check pulse, blood pressure, volume status assessment. Volume status can be assessed by clinical methods like skin pressure, ये तुम्हारा capillary refill, jugular venous pressure, peripheral signs, axilla sweating, searching the axilla, and there are other and clinical exams by auscultation. If you find crackles in the lungs, look for auscultation. Clinical meticulous and judicious and diligent clinical examination का कोई सा alternative नहीं है. आप मैंने ये देखा है कि आप जितने पेशेंट के साथ डिलीजेंस के साथ काम करेंगे, देखिए मेडिकल साइंस इज नॉट ए वेरी रॉकेट साइंस. व्हाट मैटर्स इज डिलीजेंस. मेडिसिन में ब्रिलियंस की जरूरत नहीं है कि सुपर ब्रिलियंस को जरूरत होती है रिसर्च करने में, जेनेटिक चाहिए, हार्वर्ड चाहिए, वहाँ चाहिए. बट व्हाट मैटर्स इन क्लिनिकल प्रैक्टिस इज टाइम एंड डिलीजेंस. तो जितना आपने वो कर लिया है ना, उसी से बहुत बढ़िया रिजल्ट मिलते हैं. सो astute and aggressive clinical examination is a very must. Sit with the patient, see the patient, आपका confidence बढ़ेगा, patient का confidence बढ़ेगा, और definitely हो सकता है उस समय आप diagnose ना कर पाए, उस समय assess ना कर पाए, लेकिन 8 घंटे बाद आपके पास thought आ जाएगा नहीं यार ये करना है, और ये चीज़ें ठीक हो जाती हैं. So clinical examination ऐसा नहीं कि एक बार कर लिया, clinical examination continuous चलता रहता है. Patient critical patient में ऐसा नहीं आपने एक बार देख लिया, आपके continuous thought process में रात भर चलता रहेगा. So clinical examination जो पेशेंट पे वहाँ पर है वो देखा है, उसके बाद भी आपके दिमाग में चलता रहता है क्लिनिकल एग्जामिनेशन. सो डिलीजेंस इज वेरी इंपॉर्टेंट. सो वॉल्यूम स्टेटस असेसमेंट, क्लिनिकल एग्जामिनेशन. नाउ द थिंग्स हैव नाउ विद द हेल्प ऑफ एक्स-रे यू कैन गेट आइडिया ऑफ फ्लूइड ओवरलोड. बाय पॉइंट ऑफ केयर अल्ट्रासाउंड you can do the volume assessment by assessing the inferior vena cava. So by these methods you can assess the volume status. If the patient is volume depleted, give the volume. If the person is depleted, if the fluid patient is overload, restrict volume. So volume assessment and its correction, very important. Timely correction of volume, very important. Timely assess the volume. Patient with clinical course will have definite improvement and give rise to dramatic result. Evidence of AKI, other organ involvement, liver, skin, brain, and heart and blood vessels. So other signs of injury you can find in other organs also. Now urine assessment. Look for hemoglobinuria. The patient hemoglobinuria, most common cause of hearing, Jhansi, malaria, and G6PD deficiency. Patient G6PD, classical example, G6PD deficient, Usually patient taking quinine and tonin, especially primary care in that, they come with a cold urine and present with acute kidney injury. So you can find hemoglobinuria, myoglobinuria because of rhabdomyolysis. Rhabdomyolysis is caused by seizure, prolonged immobilization, toxins, statins. So there are many causes of heavy exercise. We have seen many patients of rhabdomyolysis following heavy exercise. Two children, one few days back, one inmate from the jail came who was given, who had broken rag in the jail. He was asked someone to take 400, 500 sit-ups in a session. So he did 300 sit-ups and came with the thigh swelling, thigh pain and anuria. He remained in anuria for 10 days and he was dialyzed, given supportive care and patient improved. So this happens. One patient came to us, he was from BCL, who was new to swimming training. He did a massive swimming training and presented with severe abdominal pain. Severe abdominal pain. Abdominal pain was nothing intra-abdominal, that was a muscle pain. CPK was very high, 4,000, 5,000, giving rise to that was a rhabdomyolysis because of exercise and taking care, good supportive care and patient improved and discharged. So these patients will give you reward. Hematuria, look for urine, highland cast, different cast. What do you mean by cast? Renal tubules, they are longitudinal. The long tubes are the tubes. So anything which take the shape of tube, they are called casts. So casts are always in a tube. In granules, they become granular casts. Granular cast contains a lipid, they become waxy casts. So there is also importance of examination of this very examination of urine examination, and urine examination should be examined within half an hour of voiding. Because if you allow to stay urine outside for many hours, the casts, cells, they disintegrate and clinical relevance of examination urine will go away. We have a picture of different casts. You can see epithelial cast, epithelial cells, tubular epithelial cell. They are dysmorphic RBC. Dysmorphic means the shape of the RBC has changed in the urine. Monomorphic RBC. Dysmorphic RBC, presence of dysmorphic RBC in the urine is the surest sign of glomerular bleed. Blood in the urine can be of two sources. This can be urologic bleed, this can be nephrologic bleed. Urologic bleed means blood coming from the RBC will have monomorphic. The shape will not be changed. And glomerular hematuria, when the RBC comes through the glomerulus, they pass through the tubule. As they filter through the glomerulus and pass through the tubule, the shape of RBC change and they become dysmorphic. So presence of dysmorphic RBC means the RBC blood is coming from glomerulus, and this is because of glomerulonephritis, not because of urologic bleed. Urologic bleed usually because of renal stone, malignancy, or renal tuberculosis. You can see the RBC cast, you can WBC cast, fatty cast, waxy cast. There are different crystals found in the urine. WBC cast. WBC, what about WBC cast? Presents one of the surest signs of acute pyelonephritis. Acute pyelonephritis means upper UTI. If you find WBC cast, this will indicate acute pyelonephritis. RBC cast means the bleed is from glomerulus. This is a sign of glomerulonephritis or maybe a sign of rapidly progressive glomerulonephritis. Hemoglobin cast found in hemoglobinuria, hyaline cast, waxy cast and found in nephrotic syndrome, granular cast and found in acute tubular necrosis. Now lab investigation. Simple urea serum creatinine, which is normal regular, I have discussed here. Normal serum creatinine urea ratio is less than 1:20. This is very important. Suppose creatinine is normal is 1.2 creatinine, suppose creatinine in 2, urea should be around 40, 1:20 ratio. Then urea should be around 40-50. If there is disproportionate rise of urea, suppose creatinine is 2 and urea is 200. Welcome sir, VC sir, Mukesh sir, Pandiji have come. Reports of nephrogenic subcutaneous fibrosis, which is a very dangerous disease, diffuse in nephrogenic systemic fibrosis, and there is no treatment for this. So gadolinium must not be used in a renal failure patient. This is a very important point. Kidney biopsy. There are certain conditions where you require kidney biopsy in acute kidney injury. For example, there is a classical patient of acute gastroenteritis who has got massive diarrhea, massive vomiting, dehydrated, and comes to you with a severe renal failure, serum creatinine 10, metabolic acidosis, dehydrated. This is a classical scenario. You do not require biopsy, simple correction of sepsis, correction of volume, and if required diuretic support, and patient will recover within usually 7 to 10 days. Patient will come out of it and will have a good course. But kidney biopsy is required. Kidney biopsy is required in acute kidney injury only when you suspect other diagnosis than acute tubular necrosis. That is, if your urine is angry. Angry urine means presence of RBC in the urine, presence of RBC cast in the urine, and proteinuria. This is an angry urine. When you will find angry urine, always do biopsy. Biopsy as soon as possible should be done. If you are suspecting other diagnosis of acute tubular, other than acute tubular necrosis, like suspecting drug causing acute intestinal nephritis, then you do the biopsy. If you are suspecting RPGN causing a renal failure, you must do the biopsy. So there are some indications of biopsy. If you have a classical, typical course of acute kidney injury, you do not need to do biopsy. And there are certain conditions where serum creatinine rise without renal failure. There are higher muscle mass, muscle injury, meat-rich diet, destruction of intestinal flora by antibiotics, and some drugs, trimethoprim, famotidine, fibrate, they increase serum creatinine without actually having acute kidney injury. A few days ago, one of the IPS officer showed me the report that said, Dr. Sahab, I have a creatinine 1.9 and this is worrisome. So then I took the history, everything was normal, BP normal, sugar was normal, kidneys are normal, urine was normal, everything was normal. Then I further discussed. Then he said, Dr. Sahab, day before day I had a massive amount of meat intake. We had massive amount of meat. So because of that meat, dietary creatinine reached creatinine in the meat was responsible for the rise of serum creatinine in the blood, and within 4 or 5 days serum creatinine became normal. So there are some conditions where serum creatinine rise without renal failure. And there are some conditions where the serum creatinine actually decreases even in the presence of renal failure. And these conditions, creatinine derived from muscle, when there is less muscle mass, naturally creatinine will be low. And this is female gender, elderly, malnutrition, vegetarian diet, pregnancy. What happens in pregnancy? GFR is normally 80 to 120 ml GFR. In pregnancy, 50 to 70% GFR increase. So GFR goes to 150 ml in pregnancy. So naturally, as the GFR will increase, so creatinine will come down. So creatinine normal pregnancy level in creatinine is 0.8. If you find serum creatinine more than 1 in pregnancy, this is a worrisome point. You investigate for this and accordingly plan the treatment. Right? And there are some conditions, rise of blood urea without renal failure. Renal failure सब नहीं है, लेकिन फिर भी यूरिया बढ़ सकता है. ये कंडीशन है हाइपर एलिमेंटेशन, GIT मैंने बताया आपको, हाइपर कैटाबोलिक स्टेरॉइड इन्फेक्शन, हार्ट फेलियर, tetracycline, steroid, chemotherapy. There are some conditions where urea can rise without actually having renal failure. Now complications of AKI. If you have AKI, now complete complication and management. So complication you have to address aggressively because some complications of AKI is a very good diagnosis. 90% patients are recoverable. 80 to 90% GFR recovery, complete recovery. But my experience is acute tubular necrosis because of volume loss, snake bite, myoglobinuria, immunoglobulin drug. They almost, if you take good care of them, they almost always recover. But certain complications you have to address, especially hyperkalemia. Hyperkalemia is very dreaded complication. Hyperkalemia will give rise to cardiac arrest. I have seen patients on potassium 8 or 9. We are doing CPR, giving calcium gluconate, soda bicarb, CPR, and dialysis simultaneously. We have seen patients like this. We are doing CPR on one hand, on another hand, calcium gluconate will be infused, soda bicarb infused, and insulin will be infused, and patient also will dialysis. And we have taken patient out of this turmoil. So always again say, diligence always matters. Never in medicine, never you should have. We all have never quit attitude. तो मेडिसिन में तो नेवर एक्यूट हमेशा रहता है। आपने देखा होगा कि आपको 35 मिनट तो भी CPR करने से भी पेशेंट बच जाते हैं। कई बार मैंने देखा कि 25 मिनट CPR हो गया, वो हो नहीं सकता, फिर मनाया नहीं, ये नहीं करते हैं आज को, पता लगा कि 35-40 मिनट तक CPR का वो पेशेंट बच गया। सो मेडिसिन में ऑलवेज इन नेफ्रोलॉजी और मेडिसिन ऑलवेज वन शुड हैव अ नेवर एक्यूट एटीट्यूड। So next complication है metabolic acidosis, hyperphosphatemia, hyperuricemia, volume overload, metabolic acidosis, and hyperkalemia. They are the dreaded complication. They can give rise to acute mortality or severe morbidity. So this should be identified well within time and should be managed aggressively because they have a management of these will have a rewarding result. Other complications like pericarditis, pericardial effusion, tamponade. This is a massive pericardial effusion and a CKD patient. This patient was having cardiac tamponade, but fortunately, timely patient could be the hospital, drained, given effective dialysis, and the patient survived. This is a pulmonary edema, bilateral effusion, pulmonary edema, right-sided pleural effusion. The ECG schedule of hyperkalemia, tall peak T waves, and absent T waves. And severe more than 8 almost become sine wave. Now management of pre-renal AKI. Simple correction of hypovolemia. This is done with the help of tomasaline, lingalactate. Albumin sometimes required. There is severe hyperalbuminemia. Management of heart failure. There are some conditions where patient present with cardiorenal syndrome. For treatment of cardiorenal syndrome with diuretic, diuresis, ultrafiltration, inotropic support, vasodilators for reduced after load reduction, mechanical support to increase the blood pressure, intra-aortic balloon pump. There are some conditions the patient you have come across the cirrhosis patient with acute kidney injury. So management of liver failure and hepatorenal syndrome by IV albumin, diuretic, and albumin plus midodrine and interdepression. This is very important. Management of thrombotic microangiopathy. There are certain acute kidney injury patients who present with severe anemia, thrombocytopenia, and evidence of hemolysis in the form of severe anemia, raised bilirubin, and high LDH level. This diagnosis of these patients are HUS actually. Thrombotic microangiopathy patient, they are HUS patient or thrombocytopenia purpura patient. Most common cause is this is almost because of complement dysregulation. In children, this is because of post-diarrheal. In adult, this is always almost atypical, and diagnosis, especially for pregnancy. In pregnancy, postpartum, this is very important diagnosis. If you fail to diagnose this patient, because treatment of this is different. Plasma exchange and effusion. If you do timely plasma exchange, patient can recover. If you fail to do this, patient will go into CKD. So what about promoting management of this thing? And this is we have discussed. Indication of renal replacement therapy. A single one word about we actually dialyze in the renal failure we dialyze patient not urea and creatinine. So we always focus on we should dialyze the patient, not we dialyze urea and serum creatinine. We may give dialysis to add serum creatinine 5. We may not dialyze patient at serum creatinine 8. So the clinical importance is very important. But still there are certain definite indications where you have to do dialysis. Volume overload, hyperkalemia, metabolic acidosis, severe urinary encephalopathy, pericarditis, bleed, prolonged anuria, progressive agitemia. So this was my last slides. Thank you very much.
Thanks, respected sir, for delivering such a wonderful talk.